I'll just put my 2 cents on it. I don't think there's a lot of research, and the concept is you go into this chamber with high oxygen level for, I don't know what the duration. Usually you have to pay out of pocket. It's like $300 plus per session. I've had several patients who have gone, and I usually say, it doesn't hurt except your wallet, and there's no evidence that it will help. And in some of these cases I've seen, I really didn't think that it was helpful. I think if you're going to use that kind of treatment, you should probably do it at the early stage compared to when the head is already collapsed, because it's really hard to recover with even with high oxygen. So if you're going to try it, but I'm not condoning it. I don't think in terms of the scientific basis, I don't think there is any evidence to suggest that that works.
I think that's a good question. I think we're always balancing as physicians the effect on the kid and the effect on the family with the understanding of the improvement that it has to the disease. So Harry can talk a little bit about maybe his research, but we know that in theory it is helpful, and we know that offloading the hip is better in animal models, but it is a big deal to ask a kid to be non-weight bearing for what can be months. Especially younger kids who may not be able to use crutches or a walker effectively and basically need to be in a stroller or a wheelchair. It sounds good, the first visit that families have, and everybody's geared up to do it. But as you talked about in your talk, this is a marathon, not a sprint. And after month 2 and month 3 and month 4, it becomes a lot harder to maintain that ability. So that perfect world with the bubble wrap would be great, but it is not feasible. So I usually present to families, this is what we would love. This would be a perfect situation. Let's just do what's realistic in your family environment and do the best we can to limit the loads.
If I could add, I agree with what Woody said, but I think we just have to be careful what stage the patient is in and what is the age of the patient before we recommend non-weight bearing, because for usually most of the children under 6, they tend to do well regardless of treatment, unless they're the ones that are going to develop very severe collapse of the head and stiffness of the hip. So I think you have to be sort of careful about that. I think the situation where you do want to institute non-weight bearing early are the older kids who are in the sort of initial stage. And as Woody has shown that diagram, you see how the femoral head will lose its roundness, especially during the fragmentation stage. And that's when you want to protect that head. And as the head kind of recovers, you want to also allow the child to put weight on it and stimulate the further reossification. So I think it's very so there's some details that has to be looked at, and non-weight bearing should not be just instituted as a general treatment for all, because I think not all children will need that kind of strict non-weight bearing treatment. I think it's very important that when your child has Perthes, you need to go see somebody who deals with Perthes, because if you only see 1 or 2 Perthes a year, obviously your sort of comfort and expertise and the assessment is going to be different from people who see Perthes on a regular basis. I think, and this is where IPSG has formed, so that collectively we've basically now treated probably thousands of patients with Perthes disease, and we have right now close to 800 patients enrolled into our studies, and so we learn from all the data we collect and discussions we have. But you go see somebody who really has a very low volume of Perthes, then they would just sort of have a general treatment that may not be specifically sort of indicated for that specific situation. So what happens when the blood supply gets disrupted? There are cells in the ball that are affected and die, and there are cells that still are under what we call hypoxic or low oxygen condition. And these cells, because they're stressed, they will release growth factors and signals to the rest of the body that there's something bad going on the hip, and that includes what we call angiogenic or revascularization stimulating factors. That's why we've known that Perthes is a self-healing disease, because the body will eventually heal itself and will have complete restoration of blood flow. The issue is just like what he has shown in that diagram. When the head deforms as the head is recovering its blood flow, that it will then bring in cells to remove the dead bone, which makes it weaker, and that's usually the fragmentation stage, and the bone will build back on, and that's the reossification or rebuilding stage. And the flattening of the head may not recover, and that's the issue. In general, just as Woody has shown, that in a younger child, because of the pixie dust or because they have more growth factor that they release, and they have more ability to remodel and regrow, the recovery is much better than older patients. So that's why we sort of focus more of our operative treatment as well as non-weight bearing type of treatment in older patients who get Perthes.
We generally talk about lower impact activities, which are obviously depends a little bit on the age of the child and what's age appropriate. But certainly in warmer climates or when you have access to a pool, that stuff is great. Kids generally love swimming, and it's a nice way for them to be outside in the summer and get some physical activity, but do it in a way that does not load their joints as much. Another one we often talk about is bicycling. The motion of up and down. It doesn't provide you rotational motion, but it does give you some up and down motion, which I think is a good thing for the hip in a way that does not load it significantly. I think that in most people are trying to avoid the heavy running sports at the very least, and those can be more challenging. But sometimes you can be creative. We have kids that play, sled hockey and things like that are a little bit active, but not so much impact. So there you have to be creative, and there are some things out there. It is a challenge for sure. I mean, most of these kids are at the prime years of running around and playing sports and things like that. So it is hard on families for sure.
And one pointer that I like that we got from one of our IPSG colleagues in Sweden, this isn't really an activity, but she recommends that to her patients that they sit in chairs backwards. So if you think of those sort of smaller kids chairs, if you turn them backwards, then kids are actually kind of straddling the back, and they might feel like they're kind of cool because they're sitting in it backwards, but they're actually getting a little bit of a motion or a little bit of a stretch at the hip when they're doing that. That's another pointer that I give families.
The motion is good, just like what he said. It's the impact that is not good at certain stage of Perthes disease, like the fragmentation stage. So every time a child takes a step, they usually put 2.5 times their body weight with each step to that femoral head. And if you're running, it goes up to probably 5 to 6 times their body weight with each stride. And that's in a very active child, that could be 8,000 to over 10,000 steps a day. And that's what you want to sort of limit during the active, like the fragmentation stage.
There are a lot of studies out there in Perthes disease, and I'm not aware of great literature on any of those therapies. I do think that families employ a variety of different strategies to address pain, and sometimes using hot or cold therapy can help with pain, but I don't think that we have evidence that it speeds up the process of disease.
So in general, we would tell you that as long as the difference stays under 2 centimeters, that's good enough. However, I find a lot of patients can be symptomatic at 1.5 centimeters as well. So it just kind of depends. In general, I would recommend doing if the Perthes hits you early in your life or your kid, then you are going to see about 3 millimeters of growth per year change. And so given enough years of growth left, that can be significant enough that you have to do something. So I would probably recommend an epiphysiodesis, or basically the closure of the growth plate of the opposite leg at some point in their future. That's something to talk about timing with. There are different ways you can do that with plates, or you can do it permanently if you time it correctly. But it's definitely something that a lot of Perthes kids end up doing. If you arrest the greater choke, that doesn't change that very much, but what it does, it prevents overgrowth of that greater trochanter. And so that is also something you would probably recommend doing at the time of surgery if you were doing other things.
I might add that it depends a little bit on the case of the Perthes too, that sometimes the growth plate that's kind of right under that femoral head gets very involved, and there are other times where it's barely involved or doesn't really seem to be involved. So this is one of the many reasons why we want to follow kids as they continue to grow. Even after the head seems pretty much healed, we still follow them until they are done growing, or sometimes up into 18 or even longer, just to follow for leg lengths and just follow the overall shape of the top of that femur bone, and looking at the relationship to kind of where the ball is. And then when we're talking about the trochanter, that's kind of the handle here where the hip and butt muscles insert, and kind of the relationship between the two impact kind of the mechanics of the hip.
Skip, if I could just add for the greater trochanter epiphysiodesis or epiphysiodesis, whatever you want to call it, it's usually sort of indicated in younger kids. So this is the sort of the dilemma, because under 6 patients, 80% will do well, but it's that 20% who actually develop collapse as well as growth disturbance, and these are the ones that ends up having the greater trochanter overgrowth, because that growth plate is not affected, whereas the one under the femoral head is affected. So there's imbalance in growth. But if you do need to have it, it's best done at a relatively young age. And I would suggest that age 6 or 7 probably is the ideal age versus waiting too long, because then the effect of surgery will not be sort of much as in the older, because you lose some of that growth over time.
Yeah, the hard thing is knowing whether or not you're going to actually develop that growth or rest or not. So some kids with Perthes, the growth plate does survive and continues to grow, and you don't have to do anything at all. But some of them, they don't. It just depends on the severity of the Perthes.
Yeah, so that's why you have to watch the femoral neck length as well as the widening of the neck carefully, because it's the, and then hopefully the other side is not affected, so you could compare the neck length as well as the width of the neck, as well as the morphology or the shape of the growth plate appearance on both views.
So I think this comes back to some of those principles of trying to get the hip moving, get it stretched out. So some hips that present to us are very, very stiff and very irritable. And in those hips, I think there is a benefit to kind of what I call putting the hips on ice and getting everything to calm down and getting the inflammation to calm down. And sometimes, forcing a child, even though it sounds a little bit tough, but kind of preventing the kid from walking can be really helpful, because even in the best of hands and the best of supervision, sometimes kids will be running around and doing stuff despite the parents' advice to kind of keep them slowed down. So I think there's 2 benefits from this Petrie casting, we call it, and tenotomy, which is the muscle lengthening, is that I think it does slow the kid down and calm the hip down and give it a chance to rest, which is really, really important. And it also reestablishes abduction, which we call the ability to bring your legs apart, like performing a split. So that's a range of motion that's often very, very hard for kids that have a stiff Perthes hip. And what the cast does is essentially get them into that position, help them stretch to that position and allow their muscles to accommodate. And the tightness in the muscles occurs, secondary to the irritability in the hip. And so sometimes that muscle on the inside of the groin can be very tight and very irritable. And sometimes we do a partial lengthening of that to allow that to elongate, to allow the leg to come farther out, which in turn allows the ball to get deeper into the socket. So it's a tool that many of us use. I use it frequently because I do think it works, but it is tough. It's tough on families, and that's one of the considerations when we always talk about these things.
A couple of questions, thank you, Woody, about the persistence of limp, a little bit more about the long-term outcome. Do we know the rate of total hip replacement as adults for patients with Perthes, and or how many of them will have a permanent limp?
So we actually just did a study in the IPSG looking at some of the predictors of kids that have limp 2 years out. And that's a different question than the number that need to go get a hip replacement. I would not put the 2 in the same category. I think the limp that we were studying in this particular study was that kind of painless limp that a kid might have, 2 years after having developed Perthes, and they may be running around and playing and back to a pretty much normal life. But when friends and family watch them walk, they see a little hitch in their gait. And that's a really multifactorial issue we don't fully have an understanding of. Sometimes it has to do, or a lot of times it has to do with some persistent muscle weakness. Sometimes it has to do with some permanent loss of range of motion that has occurred in the hip as a result of the disease process. Sometimes it is a leg being a little bit shorter. So there's lots of sources for why that limp might be. But what we found is that generally patients have a very mild limp, or is it generally patients have no limp, but if the limp is persistent, it's generally mild, and it's just a small minority, 5 to 6%, that have a more severe limp. And most of it does tend to get better with time.
In addition to the physio, I think, having consideration for some type of counseling or something like that may help with dealing with the emotional and mental impact. And then we talked about, I think, also having a doctor that's helping in terms of managing and monitoring the progress. And I think those are the main healthcare providers that I would typically think would need to be provided. Any other things that other people would add?
To emphasize again, just kind of the counselor piece. I think if possible, it's helpful to include the whole family, because the diagnosis of Perthes does not just impact the child with Perthes. It also clearly impacts the parents, but also the siblings. Because, for instance, if you have a child who needs to be in a wheelchair or in cast or non-weight bearing, it impacts how the family can travel around and what vacations they can go on, and even running errands. And so I think it's important to acknowledge that Perthes can have an impact on the whole family, and a counselor can hopefully help with that.
We, as part of IPSG effort, we do collect so-called PROMIS, which is the patient-reported outcome measurement system that was designed through NIH, and it measures patients' anxiety, depressive symptoms, peer relationship, and fear, and so on. And this is why I think it's sort of important to collect that kind of data to see which child, and if the child is going through some of these anxiety and depressive emotional sort of symptoms. But what we found when we did this study at Scottish Rite was that 8 to 11 age group seems to be more resilient, maybe because they're better socialized, they've been going to school for longer, and they seem to, even though you put them on non-weight bearing as well as restriction, their emotional sort of scores were sort of within normal, whereas it's the younger group, 5 to 7 age group, I think that's the more sort of difficult, challenging for some of the children, and those are the ones that I think having some psychology support, those that have a lower score. So not everyone needs it, but I'm just saying that if that kind of assessment is done, that you may be able to reveal underlying anxiety and depressive symptoms. And that's the promise that we do as part of the IPSG effort.
Perthes in general is very heterogeneous, and kind of no matter what age you get it, there are some patients that have a good outcome and some patients that have a good outcome. And really, when we're talking about outcomes, we're oftentimes talking about hip shape, because most of our studies historically were based on x-rays. It's relatively new that we're reporting on patient-reported outcomes, and it's a good change. But I would say that if you look at percentages of who is likely to heal with a round femoral head versus a less round, a flattened or an oval shaped femoral head, you have a higher chance if you get Perthes or the onset of Perthes when you're young. And usually young means less than 6. And it's thought that you have kind of a medium prognosis, we'll say, if you have the onset of Perthes when you're kind of like 6 or 7, and then you think of kids that are kind of 8 and up in a slightly older age group, and especially if you are over 11 at the age of diagnosis, you just are pretty close to puberty and relatively close to being done growing. And so your ability to heal the hip and remodel is just much more limited. So it doesn't mean you can't have a good outcome, but your chance of having a flatter femoral head is higher.
So popping can be a lot of different things. And so that's one of these things where it's important to get a physical exam by somebody who has familiarity with the hip and the pediatric hip, and ideally with Perthes. Popping can be very benign. It can feel like the hip is popping out of the socket, and it can be nothing more than a tendon kind of running over that trochanter or that bone handle that Dr. Laine explained. It can be the ball itself kind of clunking depending on the shape of the ball and how the socket is shaped. If it's really misshapen and perhaps I wouldn't say it's dislocating, but it may be kind of finding a deeper spot in the socket and then maybe a less deep spot in the socket. So it's hard to know what popping is. It really depends on the physical exam. And it can be very benign. It can be something that's concerning. It really runs the gamut. So that's one of those things where you just have to, be seen and be examined.
So there's some research looking at the anti-inflammatory medications, specifically what we call anti-interleukin-6 drug. So what it does is interleukin-6 is one of the protein that's found in children with Perthes in their hip joint. We've actually taken some synovial fluid, which is the hip joint fluid, and measured it, and this protein is elevated, and it's known to cause chronic inflammation. So we've done some research of treating experimental models of Perthes using this anti-interleukin-6 drug, and it seems to decrease the inflammation as well as have some improved healing effects. So this is an experimental study. So and this drug is now available, and it's FDA approved for treatment of children with juvenile idiopathic arthritis and also polyarticular arthritis. So it's a relatively safe drug, although any drug will have potential side effects as well as potential complications. So that's a possible drug that could be trialed. The issue with that is trying to find somebody, especially like a drug company, that would support a trial like that, because as you know, these trials cost a lot of money. And to drug companies, maybe the Perthes is not the most potential money-making sort of like a cohort or a disease, but who knows, that could change. And this is where I think it helps to increase the awareness and also really try to, in a way, lobby for more funding in Perthes research at the NIH as well as other funding agencies. I did try it a few times and I didn't find it to be very effective, so I have not done it. I don't have any, extensive studies to show that whether it works or not. But just my empirical experience with few patients, it didn't seem to be helpful, so I stopped.
I've not ever used it in any of my patients at this point, but I generally don't use Botox much in my practice either. So hard for me to say what experience would be with it.
And I would say I've used it a couple times in hips that have been very, very stiff. We have lots of different tools that we can use to address stiffness, and Botox is kind of one of our options, but I don't think that we have great data to support that it makes a significant difference. But I think if you're dealing with a really, really hot hip that's kind of defying your other tools, that is something that sometimes we try.
I think it goes back to this concept that there's underlying inflammation. That's why your child is trying to guard that hip and not move it too much. So in those situations, it's trying to control that inflammation. And in my experience, the best way to control that inflammation is decrease the impact activities as well as walking distance and doing running type of activities. And invariably, when we institute that in the initial visit, the parents will come back and say the pain is gone, because even without pain medication, it's because that underlying inflammation gets checked or is decreased by that element of rest. in olden days, we used to admit patients into hospitals and put them on bed rest or put them on like a sling spring type of sort of like a splint or I guess that's what it is, splint, and they would get better. Their symptoms would get better anyways with that rest. So I think even a short duration of rest sometimes could be effective in managing the pain. I think, Perthes is definitely challenging because it's not very common. And, it's sort of, if you look at the overall prevalence or attack rate, it's really 1 in 1,200. So there'd only be one child in a large school of, let's say, 1,200 kids would have Perthes. So you can see how isolating, and sometimes it's hard for your primary care physician and pediatricians to make that diagnosis. So really need to beat on that drum to increase the awareness of Perthes, and would also appreciate making others aware of International Perthes Study Group. If you go to our website, perthesdisease.org, it would have some educational material as well as updates and where the surgeon locator is on the map. So that's something that you could really get involved and help us with. The other thing is to enroll your children into IPSG studies. But in order to do that, the surgeon has to be a member of Perthes Study Group, because there are certain requirements. For instance, they have to be able to perform the perfusion MRI to a protocol that we have written, so that it's in a way standardized. And some of the studies that we are doing, it's looking at specific age group as well as the treatments that we're looking to compare. Now, if your child is enrolled in Perthes IPSG studies, I think it's very important to have the regular follow-up as recommended by your physician, because we want to collect the data on how your child is doing at 2 years and especially 5 years after treatment, because those are the important time points. So please remember to follow up as you are contributing important information to our studies. The other thing you could do is donate or fundraise for IPSG. As you know, research costs money, and some of our efforts, such as having a research coordinator time, as well as travel and having these kind of meetings, do cost money. And then lastly is to volunteer expertise. So if there's some of you out there, despite managing a child with Perthes and all the other things that's going on, if you feel energetic and if you feel a passion and a heart for further increasing the awareness, as well as being part of the IPSG team as a Perthes parent champion, we love to hear from you and meet with you virtually and see what you could help us do, especially those with computer skills as well as social media skills are greatly needed for us. So thank you. And our contact information is written right there, IPSG@tsrh.org.